So how to define acute vertigo? Vertigo is perception of motion when there is no real motion. And acute, there is sudden onset of symptoms. Vertigo can be broadly classified into two categories, central and peripheral. The common causes for peripheral vertigo are BPPV, Meniere's disease, vestibular neuritis, labyrinthitis, and common causes for central vertigo are vestibular migraine, stroke, hemorrhages, and other causes. So, to start the approach, I'll take 2-3 cases so that we can understand how are we proceeding for the cases with vertigo. A 55-year-old female with episodic dizziness lasting seconds, and there is triggering on the movement of head. It was followed by a prior history of mild head injury during fall. Patient categorically tells that the vertigo lasts for less than a minute and is on the movement of the head either up and down or left and right. There were no significant associated symptoms, but obviously a positional trigger was very strong in the history of the patient. No hearing loss, tinnitus, oral fullness. Patient felt relieved in one static position. No significant medical history passed. On coming to examination, her general examination was normal, ear examination findings were normal, neurological basic examination was normal, her balance tests were normal. Mind you, her Dix Hall pipe was negative. This is exactly what ma'am said. We all do Dix Hall pipe when we have a history similar to BPPV and we miss out lateral canal. In this patient, we did a spine roll test and we could see there was a right geotropic nystagmus indicating that it was positive case for right lateral canal defect. We did a simple Buffoni's maneuver and the patient was absolutely fine. Case 2. 40-year-old male with the history of acute onset of severe vertigo which lasted more than 2 days, sudden in onset, continuous, without any positional trigger. It lasted for more than 48 hours and the patient has no relief since. There is persistent feeling of imbalance, unsteadiness while walking, significant nausea and vomiting, no oral or visual disturbances, no significant past history. He had a history of cold and sore throat 7 days prior to the onset of vertigo. If we take a real good history in patients with vertigo, there are good chances. I will say there are 80% chances that we will be able to clinch the diagnosis. A viral prodromal infection, prior history, goes towards the diagnosis of vestibular neuritis or labyrinthitis. I will proceed. General examination was normal, ear examination was normal, cranial nerve examination was normal. Romberg says the patient had a sway towards left side. Head impulse, again the patient had positive left head impulse test. On nystagmus, the patient had a horizontal reading nystagmus toward right. So, we know by the previous examinations that his left vestibule is affected, but the nystagmus is on the right side. We know a patient of vestibular neuritis, the nystagmus beats towards the healthy side. So, this was a case of vestibular neuritis. Obviously, Dix Hall pipe and hearing tests were normal. This was the right beating nystagmus in the patient, horizontal, increase in the right beating right side. Now, how to differentiate a patient with vestibular neuritis and labyrinthitis? Only two symptoms. Hearing loss and tinnitus will be present in a patient of labyrinthitis. A patient with similar history, hearing loss, tinnitus, vertigo, can also be Meniere's disease. But how to differentiate both of them? In labyrinthitis, the sense of imbalance, nausea, vomiting will be much more as compared to a patient with Meniere's disease. Case 3. 65-year-old male presenting with history of sudden onset of severe dizziness, weakness, slurred speech. There is your diagnosis. We need not move forward. We know if a patient is giving any neurological symptom, it's a central cause of vertigo, and then at this point only we can ask our neuro friend to come and intervene. The patient said the vertigo started after a thunderclap headache. The duration of vertigo was persisting and worsening with time. He had difficulty in speaking, weakness in the right arm and leg, there was blurred vision. Past medical history, he had history of hypertension, hyperlipidemia which was poorly controlled, family history of hypertension and heart diseases. Physical examination, the patient appeared distressed, had slurred speech, difficulty in maintaining focus, had a BP of 180 by 100. He appeared alert but confused. His cranial nerve examination was impaired, he had right hemiparesis, reflexes were impaired and was unable to stand. Any patient who comes to you in the emergency with the history of vertigo and unable to stand, first rule out stroke. Ears can be managed later. Obviously, the neuro team asked him to undergo for a CT scan, and it was a case of pontine hemorrhage. So, by these three cases, you realize that if you take a real good detailed history in a patient with vertigo, along with a good examination, you'll be able to clinch diagnosis in 90% of the cases. So, to remember what important parts are there in history taken with a patient with vertigo, so stoned is the mnemonic. Symptoms, often, since, trigger, pathological symptoms, neurological symptoms, evolution and duration of vertigo. Obviously, vertigo and spinning, we know there are central and peripheral causes. If there is a case of postural instability, it indicates there is bilateral vestibulopathy or a cerebral cause. Patient complains of lightheadedness and dizziness. It could be a very general cause as simple as anemia. Patient can have panic attacks, agoraphobia, bradyarrhythmias, persistent postural perceptual dizziness, migraines. And if the patient complains of linear sensation of tilt, otolith dysfunction or drop attacks like in Meniere's disease. How often the patient is having vertigo? If there is a single attack, no prior history, it's a case of peripheral vestibulopathy, neuritis or labyrinthitis, and most importantly, we need to rule out stroke. Almost daily, it's BPPV, migraine, perilymphatic fistulas, semicircular canal dehiscence, or paroxysmias. Weeks to months apart with normal intervals, Meniere's disease, and continuous with fluctuations, and probably with worsening, triple PD. If there is any trigger or past history of head trauma, it's a BPPV, it's semicircular canal dehiscence or perilymphatic fistulas, viral illness, vestibular neuritis. Also, in cases with BPPV, there can be a history of viral infection prior. Any history of phototoxic medications, vestibulopathies, and inefficient compensation, it's triple PD. Any trigger if the patient is giving the history, triggers like on the movement of head or of the body, it's BPPV or vestibulopathy. If there is a specific action which is triggering vertigo, like loud sound, valsalvas, it's perilymphatic fistulas or semicircular canal dehiscence syndrome. If the environmental factors that are causing vertigo, like vestibular migraine and shopping malls, crowded places, can trigger triple PD. Any otological symptoms. If it's only hearing loss, it's labyrinthitis, but we still need to rule out stroke because in stroke patients you can have hearing loss. If the patient is having tinnitus, hearing loss, and oral fullness, it could be Meniere's disease, vestibular migraine, paroxysmias. If the patient is complaining of autophonia, I can hear my own sound. Third, mobile window lesions. No otologic symptom does not mean a patient does not have a peripheral disease, because in patients of PPD, we won't have any otological symptom. Any neurological symptom, headaches indicates migraine, visual disturbances, speaking difficulties, difficulty in walking, anything that is a central symptom indicates it's a central lesion. But if a patient says he does not have any central lesion, could indicate still that patient has a peripheral cause. How does the vertigo evolve? Acute onset with gradual improvement, vestibular neuritis, sudden attacks with symptom-brief intervals, Meniere's disease, worsening of the symptoms, triple PD or in cases of stroke, and stable with fluctuating course, other forms of vertigo. How long does the episode of vertigo last? If it lasts from seconds to minutes, it is BPPV, migraine, paroxysmias or lymphatic fistulas. Minutes to hours, Meniere's disease or vestibular migraine. Hours to days, it's vestibular neuritis or labyrinthitis. It improves with time, and continuous with fluctuation is bilateral vestibulopathy or peripheral triple PD. So we realize that if we take a detailed history, again and again I'm focusing on the history part because these are certain catchphrases. If you are able to identify the patient's history, you are heading more close to the diagnosis. For examining a patient, we have this performa where we sequentially evaluate all these certain points and then plan further. The voice, speech, facial movements, tongue and soft palate indicate towards any cranial nerve abnormality. We being ENTs, we should definitely look into the ears because sometimes a case of complicated COSOM presenting as vertigo can be simply missed if we don't look into the ears and we keep on examining whether it is a central or a peripheral cause. Eye movements, head impulse indicates towards peripheral cause, skew deviation, that's a central cause. Movements of nystagmus, in all the cases spontaneous, whether it's unidirectional or bidirectional. Saccades, whether it's horizontal pursuits, horizontal and vertical. Diplopias, we need to check the fine touch temperature sensation in face and the body. Finger nose test, dysdiaplocokynosis. standing up with support, without support, with eyes open, with eyes closed, just to rule out if there is any central cause. And if everything is normal, definitely go for all the positional tests, starting with lateral canal first. How a head impulse test is done? We thrust the patient head in one direction and we check if the patient eyes fixed to the target or not. In this patient, you can see when the patient's head is thrusted towards the right side, there is no catch-up cigar. No catch-up cigar. Now when the head is thrusted towards left, you can see her eyes missing the target and coming back to the target. This is a positive case of head impulse test in the case with peripheral vestibular cause. There are two algorithms, hints and stand-in. In hints, we do head impulse test, which indicates towards a peripheral cause. We do a nystagmus evaluation. If there is any central or peripheral cause, we can check by unidirectional or variable nystagmus. We do a test of skew, where there is any vertical misalignment of the eye, which indicates a central cause of vertigo. And hints plus, where we include a hearing assessment of the patient. In this test, we can see on covering the left eye and now moving to the right, there is no vertical misalignment of the left eye. But here we can see the vertical misalignment of the eye, indicating a positive skew in patient with central pathology. Interpretation, benign hints, when the HIT is positive, there is unidirectional nystagmus but no skew deviation. Dangerous hints when skew deviation is present, indicating it's a central cause. Hints plus when we include the hearing assessment. Remember, a patient with BPPV will have hints test negative because his head impulse will be negative, he won't have any nystagmus, his hearing will be normal, no skew deviation. But only the nystagmus will be introduced or induced in a positional test. This is the standing algorithm. So we check for spontaneous nystagmus. The spontaneous nystagmus is variable or fixed unidirectional. Variable spontaneous nystagmus indicates towards a central cause. Fixed unidirectional nystagmus indicates that it's a peripheral cause, but we do a HITS examination. If it is negative, we go towards a central cause. If it is positive, it's a peripheral vestibular disease. If there is no spontaneous nystagmus, we check for positional tests. If the nystagmus is present in positional maneuvers, it's a case of BPPV. If the nystagmus is absent, we check if the patient can stand or not. If the patient is able to stand, it's a peripheral cause. If the patient is not able to stand, it's a central cause. Investigations that we do: audiogram, caloric testing, electrocochleography, ENG, MRIs, and in the end, MRI brain with contrast, CIS protocol with angiography and venography. There are many more investigations that have come up: oculography, dynamic visual acuity, that help in aiding the diagnosis where we are unable to find one. So the take-home message is: a very good history taking of the patient is important. A good general physical examination is important, so that we can clinch towards the diagnosis, and if need be, we should definitely go for the investigations, because appropriate management is very important. Stroke detection is a priority. We should not miss out as simple as a serious case of stroke and consider it as a peripheral vestibular cause, because minimizing risk of missing serious underlying condition can be lethal. In the end, a happy patient means a happy doctor. Thank you.